Welcome Dr. Mukesh Sharma. He will be talking about posterior lamellar approach in ptosis surgery.
Good morning, everyone. Sorry for a little delay. Actually, my flight got delayed, and then I took inspiration from Fairuz and just came running 400 meters from road to here, and I could at least enter in time. All right. So it's indeed a matter of pleasure speaking in front of your own teacher as well as student. I can, like Professor Mandeep Bajaj was my teacher, and Dr. Chandana, like she did her training when I was there as SR. So it's a great moment for me that way. So I shall be speaking today on posterior approach ptosis surgery. Posterior approach ptosis repair was described long back by Blaskowitz, probably in 1931. And what he did was levator muscle resection along with tarsectomy. Later on, many modifications came over the time. And there are three sets of established posterior approach ptosis surgery. One is Fasanella servet procedure. The second, which is the most commonly done surgery, is MMCR or Muller's muscle conjunctival resection. Then there are posterior approach levator procedures like levator resection from posterior approach or conjunctival approach, levator plication, and white line advancement from posterior approach. So primarily, I shall be discussing first two procedures because levator surgery is generally, I believe, is still most people are doing it from anterior approach because of some significant advantages. So for mild ptosis, procedure of choice, no doubt, is posterior approach. Here we do phenylephrine test. If phenylephrine test is positive, it means Muller's muscle is functional, then any surgery on Muller's muscle would be successful, and we aim to do MMCR in these cases. If phenylephrine test is negative, still we can do posterior approach surgery in form of Fasanella servet surgery, which is primarily a tarsoconjunctival resection, so this can be done. Levator resection is hardly done in mild ptosis. So how to do phenylephrine test? We all know it. Means still 2 drops of phenylephrine, varied concentrations are prescribed, 2.5 to 10%. After 5 minutes, we check for lid lift. If it is there, around 2 millimeter of lift, if it is there, maybe 1 to 1.5 millimeter also considered significant. It means that Muller's muscle is functional and MMCR can be successful. If ptosis is moderate, then again, nowadays, most people, including me, are doing MMCR. One can do levator resection or plication also, and in severe ptosis, there is no choice but to go for a sling. In exceptional cases, one can do the levator resection. So with this background, I'll be discussing few of the posterior approach procedures. Fasanella servet procedure. Classical indication is Horner syndrome, where you get 2 millimeter of ptosis and Muller's muscle is not functional. So here the results are excellent. Primarily, result comes due to excision of tarsus plate, and every 2 millimeter excision of tarsus plate will give rise to 1 millimeter of ptosis correction. So it is most predictable that way. Only disadvantage is that you cannot resect more than 4 mm of tarsus plate because you need to leave at least the equal amount of tarsus, that is 4 millimeter or so in upper lid for tarsal stability and lid stability. And this constitutes the disadvantage also because there are cases where you can have tarsus instability or entropion after some time, in few of the cases dry eye. So how to do this surgery? This is a gentleman with left eye ptosis, around 2.5 millimeter of ptosis is there. Eyes reverted back. We are doing a modification of traditional Fasanella servet. This modification was prescribed by our teacher, Dr. Batheria. So 3 stay sutures are passed on the tarsus edge. 4 millimeter is marked on tarsus. Then instead of clamp, what we are doing is we are again passing sutures which can retain tarsus as conjunctiva without occupying the space which tiny mosquito clamp generally occupies. So after making this line with your diathermy also, RF cautery, so that patient does not bleed too much. Yes. Then these 3 sets of retaining sutures are passed from conjunctiva to upper end of tarsus, which you need to resect. So once we resect out the tarsus, this can be done either through the scissors or through your RF cautery. So once you are through with this, now when you pull up these sutures, the both the cut edges, they come together, and you don't need to struggle in suturing these two ends together. Classically described as plain catgut. Now we are not able to get it, so we are using 80 vicryl, but knot is typically kept outside on the skin, or it is buried inside, so that cornea does not have any problem of knot exposure, not rubbing on the cornea. So one by one, these retaining sutures are removed, and your inside suturing is completed. So this is the end of surgery. Very simple surgery, done very fast. This is the external vicryl, which is tied externally as we do it in MMCR. And final appearance after 1 week of surgery. Hardly there is any edema or so. So this is about MMCR result. In both the eyes, Fasanella servate results. Both the eye Fasanella servate is done. In one eye, little less tarsus resection was done, and in other eye, a little more of tarsus resection was done. So the other procedure is MMCR. Here, instead of removal of tarsus, we remove primarily Muller's muscle and conjunctiva. Sometime a tiny strip of tarsus may additionally be removed to have augmentation of effect if ptosis is say 3.5 millimeter or so. So typically a clamp is used. These are pre-op and post-op. In right eye the surgery is done, 2 millimeter ptosis was there and beautifully corrected. So MMCR is first choice for most cases of mild to moderate ptosis with good levator function. Its advantages are that it's a fairly predictable surgery. It gives you reliable outcome without any skin scar, without any significant problem. Learning curve is less. Disadvantage is that sometimes you may end up with shortening of fornical conjunctiva in patients who may require later on glaucoma surgery, may be of little problem, but nowadays conjunctiva sparing MMCR is done, so there you do not get conjunctival shortening. Also in severe ptosis, there is limitation of this surgery, the results are not that good. So this is how it is done. It's a child done under general anesthesia. You pass initial suture, holding suture, you word the lid. This is edge of tarsus, and since in this particular case ptosis was around 3.5 millimeter or so, so we had marked around I think 5 millimeter here. So in total the resection would be doubled. It will be around 10 to 11 millimeter of tissue which is resected, conjunctiva and molars. So we have made these marks permanent by applying few marks of cautery over there. Then the 3 holding sutures are passed, and here Putterman's clamp is applied. I will be cutting around 1 millimeter of tarsus because of severity of ptosis. Then you apply again bipolar diathermy on the superior edge, so while resection they do not bleed too much. Now we are passing the pre-placed suture. What we use here is 6-prolene. So it is passed again from skin so that the knot is left on the skin, and this will be pulled out after say 8 days or so. Then in a running manner, this is passed. All over. And you have to leave allowance where you cut so that your sutures are not getting cut inadvertently. So in the end, you bring out again suture on the skin surface, then with the metal to metal contact so that your blade, it is away from the sutures. So the clamped margin is cut and your suture was there. It is just tightened up. Just for academic exercise, just to measure how much you have resected, the tissue is unfolded and measured. So it is that amount which initially we intended, and finally the knot is kept outside. So there are certain levator procedures also which can be done through posterior approach. Resection can be done, levator plication can be done, and white line advancement of levator can be done through posterior approach. But there is one distinct disadvantage, that you cannot combine these surgeries with skin muscle excision, which is needed in most levator procedures, or a limited blepharoplasty one can say. So this is a huge disadvantage. That's why I personally do not prefer doing levator procedures from posterior surgery, because in my all unilateral cases, generally I tend to do little bit of skin muscle excision for a symmetrical lid fold. Also, in severe cases, you get some amount of limited exposure in comparison to skin surgery, but still yet you can reach up to the ligament from Whitnall's ligament from posterior approach also. So this is not a big problem, but this is a major disadvantage. So this is posterior approach levator surgery. So to conclude, there are many posterior lamellar options also for ptosis surgery, but MMCR stands out. It's a simple, predictable, relatively complication-free surgery, though it cannot be done in severe ptosis. We must always explain, as in any plastic case, realistic result to the patient. I believe in the philosophy of under-promising, over-delivering, so always say patient some guarded results, and if results are better, then patient will be happy. And side effects should always be explained to the patient. Thank you. Thank you for your patience hearing.
Thank you, Dr.
Mukesh,
Sharma.
I just want to ask you one thing, that in which cases do you prefer fascicular servet over MMCR?
Sir, only in those cases where the ptosis amount is quite less. If it is 1 to 1.5 millimeter ptosis only, then the predictability with MMCR is not that much. There are chances of overcorrection with MMCR, but with fascicular servet, you get absolute pinpoint predictability, 2 mm of resection, 1 mm of correction.
But
So
isn't it preferable to leave the tarsal plate alone and sort of just work on the conjunctiva?
yes, sir, but that's what the most people believe.